another edition of the Physiotutors podcast. Today we have with us Enda Kind, a sports physiotherapist, a specialist in strength and conditioning training, an educator, a researcher, and also, as you've probably noticed, you might recognize the name, the author of our Tendinopathy's Big 3 course that we have online. Enda works with elite athletes from the NFL to NBA to rugby to Premier League football, you name it. We're going to enjoy picking his brain today on the return to sports aspects of tendon rehab and also a little bit more deeper into things like the kinetic chain. But look, that's enough from me. Enda, why don't you give us a quick 1-2 minute introduction to yourself and then we'll just dive on in.
Thanks, Sonny, and great to get speaking. Yeah, so my main role is as head of performance at the Sports Surgery Clinic in Dublin. Sports Surgery Clinic's a private orthopaedic hospital and sports medicine centre where we amalgamate, I suppose, clinical practice and academic research. So my role is split between clinical practice, dealing primarily with lower limb injuries in more athletic populations, but also in non-elite populations, and combining that with continual professional development of our staff here within the sports medicine department and our ongoing academic research. I'm involved primarily in our ACL and groin research programs. I've recently finished my PhD in the use of biomechanics after ACL reconstruction. So dealing primarily with lower limb injuries and chronic overuse injuries relating to whether that's long-term ACL rehab, athletic groin pain, or recurrent acute or chronic presentations of tendinopathy or soft tissue injuries.
Grand. But at this point, I'm sure anyone listening to this has a pretty good idea of what tendinopathy is. So we're going to skip right over the sort of nitty-gritty pathology side of it and the in-depth physiology aspects. We're going to jump straight in. What is it that you're looking for when you have someone come into your clinic and you suspect a tendinopathy? What's your assessment strategy, things you're looking out for in your patient history and some of your DDs that you're going to go through?
Yeah, I think the first thing you're looking to understand is why and sort of why that athlete or that patient is presented to you. Generally, if they're coming to me, conditions are probably a little bit more chronic in nature. But what is about the way that they move or their physical capacity or the activities that they participate in that has led to overload either acutely or chronically of that tendon? How irritable is their presentation currently, more so in relation to the intensity with which you'll pitch their rehabilitation, and what are their expectations and understanding of their injury? Do they understand why it's occurred, the factors that have driven it? Do they understand where they are currently in the rehabilitation pathway? And do they understand what it's going to take to get them from A to B and back to play? A lot will come and say, well, I've done lots of rehab and it doesn't feel any better. And so you kind of have to deconstruct that a little bit and say, well, look, what have you done? And how have you done it? And how does that relate to how you presented then and how you present now? So you're really looking to get a profile of that athlete to understand, I suppose, reconfirm the anatomical diagnosis to make sure that the symptoms are coming from where we think they're coming from. But even more importantly, then, why has that structure become symptomatic over a period of time? And why is it that they're in a cycle of ongoing irritation of that area? And how can we begin to build a program that will take them back out of that?
So then with regards to the assessment itself, then what are you going to be looking into? Let's just, if we take the Achilles or the patellar tendon, quadriceps tendon, what sort of things are you going to be looking for, feeling for, listening for when you're talking to them?
Yeah, I think you want to split it into two. You want to split it into your anatomical diagnosis and your rehab diagnosis or your biomechanical diagnosis. So in your anatomical diagnosis, you're really trying to get a confirmation of what the likely injured structure is. You're going to be using your various clinical tests to try and confirm that diagnosis with or without imaging as required, depending on your level of suspicion or the mechanism of injury. You're going to be screening for systemic conditions that might contribute to that presentation and maybe blurring the lines a little bit in terms of why they become symptomatic. But then for the most part, you're transitioning then towards an understanding of their current loading and how they've become symptomatic, and then developing a profile of them physically in terms of their intersegmental control or motor control or kinetic chains we talked about earlier on, how they coordinate their movement, their force producing capacity or strength, either at local muscles, so let's say at the gastroc and soleus specific to the Achilles, but also then throughout the rest of the kinetic chain. You're looking at their ability to produce and absorb force at speed. So again, their jump capacity, their rate of force development, their plyometric ability, And then you're looking to examine their provocative activities. That may be running mechanics, it may be change direction mechanics, it might be kicking, it could be something specific to their sport. So you're really looking to build a holistic profile, because I can be very strong, whatever strong means, but not have that ability, that reactive strength or plyometric ability, which may lead to ongoing overload. Or I might be very strong, but I'm very reactive, but have poor running mechanics, or running mechanics that contributes to overload in that area, or just poor load management strategies. So I think you're trying to profile that athlete and say, look, we might have 5 athletes who have Achilles tendinopathy, but they might be playing 5 very different sports. They might have 5 very different baseline physical capacities. And therefore, rather than saying this is my Achilles problem, you're saying, well, you've pain that's emanating from the Achilles tendon. It's, subacute in nature, but actually this is, where you're at currently from a rehabilitation point of view and where we need to build you back up from.
If I understand correctly, you keep your assessment really quite functional. So you mentioned special testing, but then the main chunk of that is really looking at the functional capacity, because like you said, these guys that you're going to be treating are going to be in a fairly chronic stage by the point they come to you. What sort of special tests do you actually use? And then you also mentioned imaging. How valuable do you think something like imaging is in tendinopathy, or do you use it more so to rule out other potential differential diagnoses?
When I'm suggesting that the functional is probably the bigger portion of the assessment, is primarily because diagnostics of tendon issues is not the most trickiest part of the process. They generally have very well mapped clinical presentations, quite clear subjectives, and your differential diagnosis narrows down quite quickly with that. The use of imaging really is more towards ruling out more severe injuries. So let's say it might be acute on chronic Achilles to ensure that there isn't a rupture there, or a large partial tear, but also then to rule out other potential causes of pain in the area. In terms of, we all know there's a very poor relationship between pathology and symptoms. So I don't think it's going to be of any prognostic value. I don't think it's going to tell you anything about the physical function of that patient or that athlete. So it's very much, again, in that, right, getting clarity around this is a patellar tendon issue, or this is a proximal hamstring issue, right? That's fine now. Next thing is, how do we move into understanding, well, why is that? What stage is that? What level of irritability does it have currently? And then what are the component factors that have led it to become symptomatic in the first place?
During your assessment, you mentioned that you're going to look at it segmentally. To break that down a little bit for the listeners, are we talking then looking both above and below the point of injury, the chain? So if it's in the knee, you're going to be looking further up and further down to look at ankle, hip, whatever. You also mentioned you're looking at their ability to absorb impact. How is it that you break down what's going to be significant and what's not going to be significant for your athlete?
Yeah, I think you're looking to attribute it back to their pathomechanics. So a good understanding of the pathomechanics of various tendon issues is important. And while there's always multiple factors, there's no one single driving incident that leads to acute or chronic overload of a tendon. A lot of tendons have specific patterns. So let's say for an Achilles, it's poor control of ankle dorsiflexion and or frontal plane foot and ankle control. For the patellar tendon, it's primarily poor control of the sagittal plane. Excessive, if you want to call it, a knee dominant landing or jumping strategy or running strategy. For the proximal hamstring, it's very much often an overstride coupled with anterior pelvic tilt and a struggle to dissociate hip extension from lumbar extension. And in the lateral hip, it's predominantly or the gluteal tendon, it's prominently an inability to control the frontal plane at both the hip and the ankle. And so many of those things are influenced by joints, both proximal and distal to the symptomatic tendon. And so if you just look at, let's say, lateral hip pain and gluteal tendinopathy as an example, obviously trunk control and in particular lateral hip strength and control will be very important, but the foot is going to play an incredibly important role in how you are able to control your hip and how you're able to control your trunk. So I think understanding the pathomechanics specific at each joint, but then how that relates to kinetic movement. So when I'm squatting, does that tell me what my foot control is like, what my anterior or posterior pelvic tilt is like, what my knee dominant or hip dominant strategy is like, when I'm doing a single leg squat, let's say when I'm doing running and jumping, etc. So having an understanding of the potential factors that are contributing to overload gives you a basis by which then you will build your assessment around.
Once you've gone through assessing this person of looking at, let's say if it is the ankle, they've got poor dorsiflexion control. Let's say it is the knee and they've got a bit more of the knee dominant strategy. What's your approach then to your initial stages of rehabilitation? Because you often read or hear of people starting with isometrics and then progressing onto heavy slow and yada, yada, yada. What's your approach of what you do in clinic with your person in front of you?
Yeah, I think it depends very much on the individual, what their individual irritability is and what their individual strengths and deficits are. So again, you may have two patellar tendinopathies with very different levels of irritability currently, but also very, very different levels of physical competency. And so you're trying to target as many of the components of rehabilitation as possible at a given point in time, depending on the severity of their symptoms and depending on their physical competency. So you may have someone who let's say, played a game yesterday and they've, quite an angry and irritable patellar tendon today, and they've decided, look, I just need to sort this out. You're not going to begin plyometric work with them on the first session. That's not, what they're going to be able to tolerate, irrespective of the level of performance capacity that they have. So I think you're looking to load the tendon as intensely as you can without provoking their symptoms. So for some that may be isometrics, for some that might be Kinetic, for some it may be more ballistic, but you're always looking to push them as hard as they can be pushed at that given level of intensity, but also depending on their physical competency. And then you look to work on their segmental control or their kinetic chain control. So looking on their squat pattern, their calf raise pattern, their single leg control pattern, and trying to identify individual muscles that require individual targeting. So that might be the quadriceps as part of a patellar tendon issue, or it may be glute max as part of a high proximal hamstring issue, and having muscles that target that specifically. Then have exercises that target that specifically, have exercises that target the compound chain. So looking at their squat pattern, their hinge pattern, their lunge pattern, as their physical competency allows and their symptoms allows, and then progressing that on to their ability to produce force at speed and absorb force at speed, whether that's jumping and landing or plyometrics, and working forward from there. So how much you can do on that first session is depend very much on the level of irritability of their presentation, but also their physical capacity. And that if they're, it's a very, very strong, long-standing chronic presentation, they mightn't have ran or jumped in a year or two, you're going to have to go back quite a bit and put in some physical capacity there before you worry about progressing on to the higher levels of rehab.
You mentioned there one of the things that you look to do is push them as far as they can go without provoking pain. Now, especially if it's the first session or second session of working with someone, do you then decide that person's loadability from what they've said their level is up to that point, or what they've been able to do up to that point? Because one of the things with tendinopathy injuries is the pain isn't always present there and then in the clinic when you get them to do a movement. It's going to be later that day or the next day. So what goes into your decision-making process there?
Yeah, I think you can probably split that in two. So one is their exercises and one is their other loads. So let's say they're running or whatever else they're doing separately. So in terms of their exercises, for me, you want them always to be able to execute the exercise in a way that has good form, as in they're executing it with the mechanics that you're looking for, and that is targeting or burning, or they're feeling it in the muscle groups that you want to feel it in. So for example, you'd have someone do the squat pattern and they'll tell you that, yeah, I feel that on my patellar tendon, but also I'm not really getting much of a quadriceps hit out of that. So the likelihood of them developing, the pattern or also B, the intensity is unlikely to be there. So I'm always looking for them usually not to have symptoms while doing the exercise, because I feel if they have a little bit when they're doing it with me, they'll invariably have much more when they go home to do it. So always looking to be pain-free in execution, always looking to burn or feel it in the muscle groups that you're looking to target. And then how you feel getting out of bed the next morning is your acid test. Okay. And so I'd be quite satisfied if they do with good form and don't have pain doing it while they're doing it. The next morning should be fine. But the next morning is really important, especially for those other activities that we talked about. So let's say someone is saying, I've had Achilles pain, I've had it for 8 weeks. To be honest with you, it hasn't really changed the last 4 weeks. It's just sitting there, it's annoying me, despite the fact that I'm doing 5K 2 times a week or 3 times a week. So that's quite a stable level of irritability. So unless there was some reason you thought otherwise, I don't necessarily think there's a need for them to roll back from that level of running, also because they have to build back up again. So you want to try and keep them at as much as they can tolerate. But if we can concurrently improve their capacity and the strength of A, the tendon tissue, but also B, the rest of the kinetic chain, we hope that at that level of running, their symptoms will improve on an ongoing basis without having to reduce their load. So I think for me, I never really see the point in having symptoms at that area while executing the exercises that you're giving them to improve their physical condition. And then concurrently, getting out of bed in the morning is, for the most part, and most injuries in general, a very good indicator of how yesterday went. And do I need to modify things either from a technique point of view or from a loading point of view to get some more momentum again.
One of the other things that you mentioned is also the importance that biomechanics can play into this person's rehabilitation and your rehabilitation strategy as well. Now, obviously, probably picking an opportune moment to speak to you about this with you recently finishing off the PhD in biomechanics as well. So it's all a little bit fresher in the head. Biomechanics, as of late, has taken a bit of a beating on social media from physios and whatnot, from not being maybe as important as we thought. I know I use it a ton in my practice when I'm working with my patients, when I'm working with clients, to ensure a good range of motion, a good between two goalposts sort of movement. How important is the biomechanics for you and the rehabilitation that you do with your patients, with your clients? And how important should it be in our rehabilitation strategies, do you feel?
It comes back to the why and understanding why certain presentations, whether that's tendon or any injury, has occurred. And so, I mean, biomechanics is the measurement or analysis of human movement. And so if an athlete is telling you they're repeatedly pulling their hamstring while sprinting, obviously the capacity of that hamstring tissue is going to be important, but also perhaps the mechanics of which they are running is contributing to that. And you can extend that to patellar tendon when jumping, Achilles, lateral hip pain, etc. And so the role of biomechanics in my clinical practice is being able to join the line between, the pathomechanics and that individual athlete and why they've ended up where they are, and working more and more towards what optimal or good looks like. And second of all, it's incredibly important for measuring the effectiveness of your programming. So if you do a 6 or an 8 week program and mechanically you don't look a whole pile different, despite that being the ultimate aim of your program, then it's incredibly important to try and decipher, well, look at, if the athlete feels no better, is that because something else is going on, or because my program just hasn't been effective at getting the adaptation change we're looking for? And the third part is that, increasingly, and you see this in the ACL literature all the time, there's a disconnect sometimes between the outcome you produce and the way that you produce it. So you often see in jumping and landing tests, you could achieve a degree of symmetry in performance and function. But when you look at the individual joint mechanics, that very often the movement strategies used to achieve that between the injured side and uninjured side can be very, very different. And so, for the most part, and tendon is no different, in the absence of a systemic disease or some other factor, load and movement are the two drivers. So how much I've loaded that tissue and the periods of recovery that it's gotten in between to adapt, and the mechanics I use to preferentially load one structure versus another. And you see this actually in some of our research in athletic groin pain, when you're looking at, you can have athletes presenting with 2 or 3 different symptomatic structures. Like, does that mean that they're really unlucky to have 3 different diagnoses, or it's the way that they're loading that area that's ultimately leading to the development of multiple sources of symptoms? And so our practice here in Dublin has definitely benefited from having an approach that focuses on why athletes are becoming sore, as opposed to it's a proximal hamstring tendinopathy, so here's my proximal hamstring program, or it's a lateral hip tendinopathy, so here's my lateral hip program. And although there may be commonalities between them, especially in more chronic presentations, so like the vast majority of patellar tendons are going to have quadriceps weakness just by the chronicity of the presentation. If you want to move from improving the majority of people to improving the vast majority of people, or nearly all presentations, having that ability to analyze that individual athlete and why they have presented is going to be incredibly important in the longer term.
Sounds like kind of what you said right at the beginning of really nailing down why the issue is happening is where the biomechanics become so important. That they've got the pathology is one aspect to it, but like you said, with a person who keeps injuring their hamstring, there's no point in just treating the proximal hamstring tendon if it's going to keep coming back because you haven't addressed the underlying issue. Would that be a fair sort of summation in your view of why the biomechanics can be just so important to ensure a long-term outcome?
Absolutely. And like when you look at the other factors, like as I said earlier, like there's a disconnect between pathology and radiology and pain. So we can't just say your anatomy looks like this and therefore you are or aren't symptomatic. So if there's a disconnect there, well, there has to be other contributing factors. And it's not only to do with the strength of the tissue, because we see people with very high levels of calf strength who still have ongoing Achilles issues. And you see people with very high levels of hamstring strength who have acute or chronic recurrent issues in their hamstrings. So that doesn't mean that hamstring strength isn't incredibly important. It just means that you can't tell the whole story by it alone. And so I think, as I said, the reality is the vast majority of people get better almost in spite of what we do rather than because of what we do. So you're looking for the ones that need our intervention, to turn things into a positivity. And it's people's frustration when I've done lots of stuff, I've done lots of rehab and I don't feel any better, or I haven't improved to the level I have. Is that because they haven't, there's something anatomically wrong? And well, if they look like the other scan of someone else who has got better, well, we can't just say the anatomy is the issue. And if they've done the same amount of strength training, well, then is it the way that they're moving is contributing to that ongoing deficit in whatever activities they choose to use?
I mean, that's something that I wanted to talk to you about with those people that are strong. So you might get a power lifter with a patellar tendon issue. Now, realistically, this person, they're clanging and banging the weights like Dwayne Johnson kind of thing. But a weakness in the quadriceps can't be the issue. So, looking at the biomechanics gives it more of a reason as to why that's going on. Where is it, do you think then, that we as physios looking at these people really need to be switched on looking at these biomechanics? Is it, like you say, looking at the functional issues in day-to-day or functional issues in the sport that we need to look at to really nail down and zone into where things might be going awry?
I think it's both. So I think we need to measure. We need to be able to analyze and say that this is contributing or not contributing. When I look at cases of where things haven't worked out as quickly as people would have liked, they've generally gone both directions. So they've gone to the more simple compound movements, maybe activities, daily living, have cleaned them up, but not brought that athlete, bridge the gap between the gym and the field, have not brought them back to the higher level and examined their higher level activities and seen how they're participating in those. Or they have, as you'll see very often in sports where there's high levels of strength, let's say rugby, American football, etc., they're moving, heavy weights, but the mechanics with which they're moving them are either not conducive to getting the adaptation they're looking for or contributing to overload in certain structures, whether that's lumbar, proximal hamstring, patellar tendon, etc., patellofemoral joint either for that matter. And so they have the high force producing capacity. However, the way that they're producing that force is contributing to ongoing irritation in the area, and or they haven't translated into the higher level activities as well. So it's trying to bridge that gap between, again, going back to profile your athlete and saying, look, do you have these basic functional capacities of strength in individual muscle groups and compound movements? What strategy do you use while executing those compound movements? Can you then absorb and produce force at speed? And have we the metrics and force plates or whatever way other strategies we have of measuring that? And then how do you transfer that capacity to other sport specific movements, whether that's speed skating or tennis or golf or whatever else it is? So you can have a lot of athletes have the same building blocks, but then move into different areas, and so therefore maybe developing or continue to irritate their tendon issue for different reasons, despite the same baseline functional capacity.
Grand. We're there already. I was planning on swinging this bit in when we're talking more heavily about the interventions, but with the importance that biomechanics plays, how do you go about coaching your patients on the improvements? Because there's internal focus, external focus, those sorts of things. Do you show them video? What's your approach to that?
Yeah, I think the first thing is they need to understand where they are, and they need to understand how that's contributing to the problem. So that's even just for buy-in alone, that's incredibly important. When you're looking at improving someone's motor control, which ultimately is a movement skill, and like any aspect of skill acquisition, you're looking to give them a problem to solve. So rather than sort of saying, don't let your knees come forward or don't let your pelvis tilt forward, you want to put them in a movement or in a task where it's either, you're constraining the task so that they can't do it and therefore have to come up with a different movement strategy, or that choosing a poor movement strategy, whatever the hell poor is obviously incorrect to them. And so, for example, like simple thing like doing goblet squats at a wall, you're not telling them don't let their knees come forward. You're just saying that I'm taking that option away from you, and therefore you're going to have to develop a more hip dominant pattern when doing so. Or doing hip lock drills for running for someone with lateral hip pain, getting them to lock into that position as quickly as possible and not fall over. Well, they know if they fall over, that obviously they aren't as stable as they should be. So you're trying as much as possible to create exercises that allow them to solve the movement puzzle themselves. And you're looking to produce a degree of variability within those exercises, whether that's creating instability or like the Tom Bernstein talks about, repetition without repetition, so that there's a little bit of variety within the exercise selection to try and reinforce that movement pattern as much as possible. And then as their acquisition of that skill, whether that's a squat or a sprint or anything else, in order to be able to progress those exercises, you can begin to become much more artistic, isn't the right word, offer greater variety in the exercise selection that you use to try and achieve that change over time. So the best, as I said to the staff here, the best exercises I have are the ones where I shut up the most and let them just do what they need to do. But we feel inherently the need to talk all the time. And there's lots of research that shows that, feedback spaced out gets much more carryover between sessions and within sessions, and letting the patient or the athlete ask you for feedback versus you shoving it down the throat the whole time is also very important. So I think understanding how your exercise will get the changes you're looking for, but also having the ability to create a learning environment is something that's very important, because you can be a great diagnostician, but that doesn't mean you're necessarily going to get someone from A to B.
And then without already being in the later phases of rehabilitation, are you, while you're in the gym setting, beginning to use sport-specific movements as well? Or are you more so focused while you're in the gym on this process of creating feel to help the movement pattern?
Yeah, both. I think the two things that I'm trying to do in the gym is improve tissue capacity. So whether that's of the tendon or of the individual muscle associated with that tendon or the kinetic chain. And you're trying to build movement patterns that are going to facilitate higher level activity. So my squat pattern is naturally going to feed into my jumping and landing pattern. It's naturally going to feed into my pattern for lowering my center of mass to change direction. My hinge pattern, or my ability to come to the top of my deadlift or my step up, is naturally going to feed into my mid stance running. And it's naturally going to feed into that side of things. So they're very much the building blocks for the movement strategies you're going to try and use later on in rehab. And so you're lowering them either at slower intensity to try and develop hypertrophy, at higher intensity to try and develop max strength or optimize tendon development, or then ballistically either concentrically or eccentrically to try and optimize rate of force development, all with a view to having the capacity and the transfer to more sport specific movements afterwards.
Great. And then while you're going through this process, or maybe a little bit earlier in the process, are you ever using any adjunct therapy such as dry needling, shockwave, TENS, complex, that sort of stuff, or any hands-on techniques? Or do you solely try to focus on exercise prescription? And
I think if we split that in two and just say, let's say, soft tissue techniques and dry needling. So I mean, both of those have the desired effect of trying to reduce muscle tone perhaps and or improve mobility. And so I mean, there's absolutely nothing wrong with doing that. I find in an outpatient setting, I don't have time to do it because I have that much exercise to work through. If I did all the stuff I'm supposed to do, that's probably not the best use of my hour or whatever time I have with the athlete. In a residential environment where you might have an athlete for 6-7 hours a day, certainly there's more room to expose that or to explore that. But very often, I mean, muscles, tighten or movements tighten according to specific deficits. So as you begin to work on your segmental control and as you work on individual muscle strength, you find that these patterns begin to open up again. So I often find that it's more useful from a learning point of view to the athlete, but also from a carryover point of view to get them moving and show them how that influences things rather than soft tissue work. In terms of the likes of complex, certainly in those that are really struggling for motor recruitment, particularly quads, either post ACL or with the patellar tendon, where they're struggling to recruit as many of the type 2 fibers as possible because of inhibition and irritability, that can be often a useful way of A, minimizing atrophy in the short term, but also B, optimizing recruitment of all the muscle motor units while doing exercise or as a warm-up prior to doing your strength work. So again, it can be very, very effective at trying to facilitate adaptation during a session.
Hey everybody, I hope you're enjoying the podcast so far. We're going to take a little break now. Just going to talk to you briefly about the course that we're doing with Enda Kind. That's out now. Tendinopathy, the big three. Advanced rehabilitation, so return to sport, return to play, what have you. Now, for listeners of the podcast, we've got a coupon code 50ENDA, that's 50 ENDA, and you can use that to get €50 off on the course. Now, I'm sure you're thinking at this point, yeah, good stuff. Now, what's on the course? Over the duration of the course, Enda goes into the physiology and anatomy, your pathomechanics and your risk factors, and how you can assess those in clinic. So takeaway points for you to go back into clinic when you finish with the course that you can utilize straight away. Then you're going to look at your rehabilitation strategies, how you're going to get player or patient A from A to Z in their rehabilitation, transitions and return to play as well, bringing it all together with case studies and also course quizzes, keeping it interactive for you with lots of videos as well. Check it out. The code again is 50ENDA, and yeah, we're going to crack on with the podcast. Enjoy. Grand. And then if we look back to the segmental control then, are you still looking at that when you're going into the later phases of the rehabilitation, or are you hoping that by the point of return to sport that you've already covered this aspect and you're really now working on return to sport?
Yeah, I suppose if you take, let's say we take change direction, you are hoping / assuming that your improvement of their strength and your improvement of their force producing capacity at speed while working on their squatting pattern will all have had a positive influence on their change direction mechanics, both their ability to lower the center of mass and the capacity to absorb load. And so if you have a very knee dominant squat pattern, the likelihood is you're going to continue to have a knee dominant pattern coming into a change direction. But just because I have resolved that in rehab doesn't necessarily mean that strategy will change at higher levels up in more sport specific movements. And so that base gives me the opportunity to change. It provides a much more likelihood that a capacity to change, but it doesn't necessarily mean that when I'm having to react to a defender or I'm trying to jump from a tennis serve land from a tennis serve, that I won't just go back to the strategy that I've done 1,000 times before in that environment. And so I feel you can't assume that what you do in the gym will ultimately translate onto the field. I feel that what you do in the gym is going to give you the best opportunity, but you'll also have to go and look at those other movement patterns, whether that's, running mechanics and sort of ankle dorsiflexion, mid stance running or foot pronation or anterior pelvic tilt. So you have no tilt in your squat or your deadlift anymore, but you start running and immediately you start spilling your guts again. I think you can't assume without assessing that those strategies will have changed automatically.
Or what are your criteria that you use when it comes time to progressing the rehabilitation?
Yeah, I think you're looking for their pain provocation. So ultimately, how are their symptoms? They're coming to you to return to pain-free participation. So, if they're pain-free, are you going to stop them starting running or stop them starting change direction or go back to sport? You're not, or at least you're not going to have a busy business for too long if you do. And so you're looking to see their symptom response and their pain provocation tests. You're looking at their overall load tolerance. So I've done X amount of high speed running this week. How does that relate to going back to fully training? Is it a logical next step as to where I want to go with that? Or I've ran 5K 2 times this week. I'm not going to run the marathon. I might run the marathon next week, but I have to understand that, the difference in where I am and where I want to go. And the other thing is that because there's this disconnect between pathology and symptoms and mechanics, it's not like there's any perfect point. And so what you're always looking for is their capacity improving? Is their symptom provocation improving or at least staying the same? And is their load tolerance improving? And everything after that then is really trying to build towards more athletic performance. So the stronger I am, A, the more robust I should be, but also B, the better athlete I should be. So you're trying to transition from a rehab program in their heads towards an athletic development program. And so it's not that, one starts here and one starts there. It's just a myriad of blurring through. But I think in tendons in particular, your morning after symptoms is always going to be a very, very good indicator of what you're doing. But I think you need your other metrics to be improving in parallel, because if you rest long enough, in theory, your symptoms will dampen back down again. So does that mean that it's time just to go? Well, if I haven't improved the load tolerance of tissue or the capacity of their movement strategies in parallel, chances are when the running load or the training load comes back up again, I'm just going to become symptomatic again.
Where do you decide for your patients, for your clients, that it's okay for them to have some kind of irritation or feedback with it? If you're dealing with elite athletes, they're the kinds of folks that can't afford to spend 6 to 8 weeks on the sideline for a full rehabilitation program. When we're working in clinic with private patients as well, you see it a lot. People don't want to wait until they're 100% okay. And my personal feelings are also that you shouldn't have to wait till someone's 100% okay to let them get back onto field, or at least begin to build up. Like you said, you space it out with a small run and build it up, et cetera, et cetera. Where do you feel like there's the tipping point of saying, hey, this is acceptable for you to return to play with this level of irritation, or actually that's too much? Have you got a way of sort of scoring that for someone, or giving them an objective way to view it?
Yeah, it's very difficult, because the first thing is what's 100%. So that can be a difficult thing to delineate. The second thing is also the context. If you have, so the final round of Six Nations games in rugby was on at the weekend. If you've a bit of patellar tendinopathy and you're playing in the second row for England, Ireland, or France, or wherever, are you going to not play at the weekend? Of course you're going to play. So it has the context. That the big thing for me is the morning after symptoms. And what's interesting with tendons is, you can not listen to them for a little while, but eventually they'll catch up with you and tell you, I told you so. And so, you want to always push on and do as much as you can all the time. And for me, the morning after is always a very, very good indicator of how that process is going. So if you push on and you're going back running or whatever else, or back training, if your symptoms are staying the same the morning afterwards, that's a win. That's not an issue. Okay. And providing obviously week on week they start to transition or trend in the right direction, improve further. However, if your symptoms are disimproving with each session, that's going to end up in trouble very quickly. So it's not even that it's my opinion, it's just the athlete will come and tell you, actually, I'm just breaking down. So I think what you're looking for is a level of activity that allows not a plateauing, that does not make your symptoms worse or is improving your symptoms. And if that's a little bit or a lot, it doesn't really matter. It's what's specific to that individual athlete. I think when you're having a level of symptoms where, and most, some athletes may have a bit of Achilles stiffness and not have to stop training at all. They may keep their load the same, especially if, you're always telling your players, if you've any niggles, tell us as early as possible, because that's when it's most easy to look afterwards. That's when it's most easy to manage. And so if we work on identifying the biomechanics or the strength capacities while maintaining your training load, you may actually never have to roll back at all, and you'll find your symptoms improve on a weekly or a monthly basis. So I think if your symptoms are disimproving the morning after activity, it's not going to work out. So there's not much point in persisting, or at least in my experience, anytime you've tried to plow on with that, it just has ended up coming back and biting you in the ass. So I think those morning after symptoms is a really good indicator of whether to push on or whether to hold where you are.
So there is a little bit of an element of maybe trial and error isn't the best way to phrase it, but give it a go and see, and stick within your limits from where that is, maybe, is a good way to...
The hard, especially let's say it's someone who's going back to activity, the most difficult session is the first session, because you're trying to work out where to pitch it. And if they're pitching from nothing, it's very hard to know, is one step up or is 3 steps up too much for that individual athlete? And that may go back a little bit to what you feel their individual physical competence, if they have great levels of strength, whatever grade is, and you might say, well, look, there's a good chance and that they'll tolerate this more. if they have poor levels of strength and a 5-year history of Achilles pain, well, then likelihood that first baby step is going to be a little bit smaller. But after that, then it should just be, fairly sensible progressions in training load and running load, looking to build back up to an amount that is a step or two below full training, so that they're stepping into training having come up the ladder, as opposed to, well, I went for a bit of a run there and it was fine, and next thing I'm going to go back to train 3 times a week. And again, some people will get away with that. So it's very difficult to say that, what is right and what is wrong. But again, if you're using your pain provocation or your symptom response as a marker, I think you'll make some more informed decisions. And nearly everyone has a little bit of spike in symptoms somewhere along the journey. And that's not a problem. That's just a reflection of where we are in our low tolerance progressions.
Okay, that kind of brings me nicely onto patient education there, the fact that you will get spikes along the journey. What is it in your view that's so important with regards to properly educating your patient on where you are, where you're going, and what can happen along the journey, essentially?
Yeah, I think you look back at the mistakes that you've made or that your patients have made, and you want to try and head them off of the past. And so your education is trying to assist them to have their rehab in a straight line as possible, knowing that that's not really what happens. And so their understanding of their anatomy and what's relevant to their presentation and what's irrelevant to their presentation, because often they come in and say, well, my scan is showing this, that, or the other. And you kind of need to filter that out and clear that up for them. First of all, their understanding of the pathomechanics, whether that's their load management or their movement strategy that has led them to develop their symptoms, so they can understand why it's happened and also how to minimize the chance of it happening again. And the third one then is their problem list, in terms of, well, if you look at your quadricep strength and you look at your squat pattern and your plyometrics or whatever else the components of that individual profile of that athlete is, and educating them as to how long it's going to take to develop an adequate level of function in those metrics. So let's say someone has, just pick something random, has a 50% asymmetry in calf strength. You're not going to close that out in a week and a half. So you need to offer context to your assessment, how that relates to the program that you've given them, and how that relates to, we know that obviously tendon changes take quite a long period of time, especially with training at high loads. But very often, their symptoms will improve and they continue to improve well in advance of those tendon changes taking place. So I think having context of, if you want to get from A to B, you're going to need to do exercises of a certain intensity 3 times a week. We're going to need to bring back in your running when you've achieved this level of competency, and we're going to need to step you back up from there. That gives them the context and understanding of, right, okay, this mightn't be a quick fix, but also I might give this Achilles injury 8 weeks. It doesn't necessarily mean I'm physically going to look or feel any different in 8 weeks' time. So it's trying to disconnect time of injury to progress in injury and get them to understanding that, realistically, this isn't going to go away. You're going to get rid of it. And the way that's going to happen is by addressing the factors that have led to symptom, which either are a consequence of your symptoms currently or have led to the development of symptoms in the first place.
So that really brings us back into the emphasis on movement strategy and working really in the kinetic chain for eliminating these asymmetries and really working along the whole chain as a whole unit. Can you give us some examples of things that you've done with your athletes where you've really tried to hammer home the principles of utilizing the kinetic chain or modifying their movement strategies to try to help them along their journey?
Yeah, I think if we take any injury, we stick with Achilles for an example, having their understanding of, that control of ankle dorsiflexion and or frontal plane control of the foot, and how that leads to or may contribute to overload of the Achilles along with your training volume. So when they're doing their calf strengthening exercises, whether that's biasing, gastroc or soleus, get them to understand, the need to plantar flex the full way through range, how finishing off in plantar flexion of the first MTP is very important for controlling the stability of the ankle medially and laterally, working not only on your calf strength, but working on your mid-stance stability, whether that's, intrinsic foot exercises or controlling mid-stance during compound movements like a squat or like a single leg RDL as an example. Then understanding not only that we're looking to control dorsiflexion from the ankle, but looking to control it from the knee as well. So how your squat pattern, when you're obviously squatting, but when you're jumping and landing, how if you have that excessive knee pattern, that's going to increase the amount of ankle dorsiflexion you have. So working on your compound movements concurrently, taking that further on then to your plyometric exercises. In particular, you see a lot of hops and bounding exercises, and the ground contacts are good or appropriate, whatever good or appropriate is. The intensity of the exercise is good, but the technical competency is poor. So their heel is smacking off the ground every time. Even though they're very rapid, they're getting massive ankle dorsiflexion forward at high speeds. And so regressing that exercise back to a level where they can control anterior tibial translation or control ankle dorsiflexion is every bit as important as the intensity of the plyometric exercise you've given. And so time and again, you'll see athletes doing depth jumps and drop jumps off boxes, and actually they can't control a simple single leg pogo with good technique without allowing that knee dominant ankle dorsiflexion. So taking that through, and then obviously progressing on to running mechanics in that, I can have all this calf strength and reactive strength ability, but if I continue to have a long mid stance, to continue to collapse forward into dorsiflexion or of a slow heel lift during toe off, that's going to influence, the load, the amount of work done through the calf, and the amount of work done through the Achilles, and the overall load tolerance. So again, it's trying to look at the capacity of the individual tissue, the musculo-tendinous unit, and then look at the entire kinetic chain, not only looking at the chain at individual exercises, but through the different movement intensities of strength, power, plyometrics, and running, and sort of seeing that there's money to be made at all these different levels of capacity, especially if going back to running is ultimately what you're looking to try and achieve. And all that is not to overplay the role of biomechanics, but it's to, if I want to be most effective, if I'm addressing all those factors, that gives me a lot of wiggle room. It improves my room for error, knowing that ultimately, running mechanics is no good unless I'm running. So, ultimately your running volume and the distances you're covering, load exposes the problem here. And so, rehabbing without that appreciation of building up sport specific load is a silly mistake to make as well. So we need to be bringing both together concurrently.
I think that really resonates with me, just for my own rehab after meniscus surgery, that having that ankle stiffness was something that I was seriously lacking, and it only became apparent when I was in the gym skipping, which was evidently way too soon, because I noticed as soon as I was starting to skip and put a lot more load to the right side, the operated knee, like you say, just the heel was bouncing off the ground every single time, didn't have that control. It was for myself a bit of an eye-opener of, maybe I'm not quite ready. As much as that hurt to see in myself, it really hammered home the point that you've got to make sure that this is okay, or else the knee's fine now, that's been operated, I'm just going to make myself a new injury somewhere along the chain and the rest of the way. And going back to the tendons then, we spoke about adjuncts in terms of complex, we spoke about soft tissue work. Now, what's your view on people getting injections like PRP or something like that? Maybe you can't talk about it too much, given sometimes in elite sport, that's a solution taken. But if you are able to, what is your view on something like that? Do you think that that's effective, or do you think that has a place in it? Or
yeah, I think like all these things, when you say tendon injuries, that covers a lot, from rupture through to mild acute tendon overload. And so the difficulty then is trying to apply any intervention to something that has a broad spectrum of pathology and potential desired effects. Certainly the literature doesn't support, especially in chronic presentations, the use of injection therapy or PRP, in particular in relation to tendinopathies. I have seen it used in elite sport in acute settings, so where you small partial tears or maybe acute overloads, and there has been what seems like a good response to that. And now whether that response would have happened regardless, or was it as a cause of sport, that's neither here nor there. But certainly I don't think in the literature there's the support for the more chronic presentations with the use of PRP, or certainly the literature is mixed in that area. So I think part of that might be because it's ineffective, or part of it might be that there's a broad spectrum of pathological presentations in relation to tendon injury, and trying to decipher out what suits best, especially when there's such a poor relationship between pain and pathology. It can be difficult to work out what tissue is the symptom producing source. So I think very much a mixed bag in that regard, and certainly not my first protocol.
What is it that you think separates out the work that you guys do there at the sports surgery clinic, the work that you do, that is different to your colleagues, that helps to give you the positive outcomes that you have? Where do you feel that you're different in that?
Yeah, I think if you take tendons as an example, it's separating out the anatomical diagnosis from the biomechanical diagnosis. So where you're sore from why you're sore. Our approach here very much is towards profiling that individual athlete based on how they move and their physical capacity, not based on their diagnosis. So you may have a proximal hamstring tendinopathy, you may have patellar tendinopathy. That's grand. The question here is, are you for rehab or are you not for rehab? Now, if you are for rehab, then I don't care about your diagnosis. The next thing now is physically, how do we profile you to see where you're at? So that's Kinetic testing for your quadriceps and calf strength. It is 3D biomechanical analysis of your jumping and landing mechanics and your running and change direction mechanics. And so from that, you can develop a profile of, here's where this athlete is at. Here are the factors that contribute. This is the program that you need based on your physical competency and also your level of irritability currently. And the ability to reassess then and make sure that what we're doing is changing those parameters. And so too often, or if I look at the second opinions I get asked for, it is very much around of, it's a hamstring problem, therefore hamstring strengthening has formed the most or all of the rehabilitation protocol. That doesn't mean that hamstring strength wasn't an important part of it, but it often is too narrow a focus in that regard. And some people will get better only with calf strengthening for Achilles tendinopathy. But then if we look at central leg out, it's more around, well, what about the 20%? And so ultimately the enjoyment in our work comes from the 20%, because they challenge our paradigms and they challenge our clinical practice. And so it's trying to have a broad scope. They say, look, we want to get everyone better. And so giving everyone the same thing isn't necessarily a strategy that's going to work, but also we want to get them better as quickly as possible. And so if we're addressing all of these components concurrently as we're able to within their load tolerance, that's going to be the best way to be effective. And it's going to be the fastest way to be effective as well.
Grant, what would your top 3 tips be for anyone who wants to get into sports rehabilitation then?
Don't do it.
That's 1 and 2. Yeah.
Don't do it. I think, advice in terms of being successful. Most people don't struggle with the diagnostics, even though that's where a lot of our clinical education has to be. So there's nothing worse than rehabbing something you shouldn't be rehabbing. Okay, so that's number one. But if you look at the people that are most successful, or that I've learned the most from, they have a great understanding of how to analyze human movement. They can watch someone squat or press up or chin up, and they're just, it's like the Matrix. They're just watching that movement strategy, and they can relate that back to their presentation. Their focus is on how you're moving rather than where you're sore. And I think then being able to take that and being able to select the right exercises to affect change, and to coach them in a way that'll affect change. We talked about, manipulating your exercise to optimize motor learning, being able to modify your exercise to target specific muscle groups is incredibly important. So it's one thing, I need to be able to understand why they're sore. So I need to understand what to do. But then what I give them needs to be able to make the difference. And the exercise select and the way I coach them is incredibly important. And so working in environments where you see lots of different exercise strategies, there's no right or wrong way of doing things. It's just where I am and where I need to be. And the fun part of our job is trying to find different ways of doing things and being able to program and periodize to get, especially in tendon presentations where obviously the rehabilitation periods can be longer and prolonged loading is important, being able to have variety in my program and progressive overload in my program, that I'm getting continuous and ongoing adaptation is incredibly important. But if I'm giving people the same exercise for 12 weeks, there will be a plateauing, whether that's a mental plateauing or a physical plateauing in adaptation and compliance. And that's going to greatly influence the success of your outcomes.
Grant, before I ask you about your learning moments, something which really interested me when I spoke with Jill Cook, and I'd like to get your take on it, was she mentioned that a lot of people, when they come with the diagnosis of tendinopathy, can be misdiagnosed. How much have you seen that in your clinical practice as well? And how much of an effect, like you mentioned there as well, you don't want to be rehabbing the wrong thing for rehab. How much of an effect can that have when someone has come up to you and they've been diagnosed with an Achilles tendinopathy, but once you've gone through your assessment strategy, you've realized actually maybe there's a chance that you weren't with an Achilles tendinopathy and you've been doing 12 weeks of the wrong stuff or not appropriate stuff, shall we say?
Yeah, I think it's interesting. Again, it probably splits into two groups. So let's say you had, adductor overload, or let's say Achilles overload, and actually it ended up being tib post or something else. Ironically, from a rehab point of view, it ends up being quite similar anyway, because you're seeing many of the same factors may lead to tib post overload as led to Achilles overload. Now, slightly different, obviously, if it's posterior ankle impingement or something like that. I think where I'm trying to think of specific cases, I'm not necessarily saying it's been misdiagnosed. When there's other systemic factors at play, whether that's rheumatic conditions in particular, I'm thinking of young male populations, or maybe young athletic populations where there may be nutritional components or other components. I think understanding other medical presentations and how that's impacting their ability to recover or their tendon health. If I look at cases where I've seen where things have been a struggle, I would say that's a very important component. Obviously around the Achilles, there are other diagnoses that you need to be aware of, but it's not a case where someone should have gone for surgery or shouldn't have gone for surgery. It's less black and white about that. But I do think not understanding your special questions and not understanding the other factors that are contributing to that presentation, especially rheumatic conditions, and then wondering why you're taking a very load-focused approach, whether that's exercise and or load, and wondering why you're not getting the reward you deserve. I think that's something you want to be very aware of early in your assessment and rehab, and to stay aware of throughout rehab, because even though they give you the right answers, whatever the right answers at the beginning, doesn't mean that the story doesn't evolve over time if the presentation isn't improving as you would expect. So I'd say that's something very important to keep in mind.
So then, moving on to the other question that I mentioned, what would be your biggest learning moments then during this journey?
The majority of your learning moments come from, either patients you didn't get better or didn't get better as quickly as you wanted, or watching other clinicians do something and why didn't I think of that? And so over time, I suppose my learning moments have come from the evolution of my assessment. So, if I have someone with a groin issue or an Achilles issue and they're not getting better despite the anatomy being what it is and the diagnosis being accurate, invariably I'm missing something. And I'm either missing something from my pathomechanical analysis of why they're developing their symptoms, or I'm missing something in the exercise I'm prescribing to get adaptation and change. And so you nearly crave the outliers now, because they're the ones that constantly make you evolve your model of assessment and see what you're doing. My learning moments in relation to assessment, certainly I've greatly benefited. We all have here from the availability of force plates and biomechanical 3D motion capture, because you see what you see, and then you look at the reports and you look at the analysis and you see that you're missing loads of things, or missing things or B, that the adaptations that you felt were occurring were not being represented in the movement strategies that they were adapting afterwards. And then thirdly, I suppose, in terms of how to affect human movement, as I said, your exercise selection evolves over time to the ones that that are most idiot proof, but also the ones that, especially when you're coming to higher level activities like running, kicking, change direction, more sports-heavy activities, trying to utilize a constraints-based approach that will allow that effective pattern to emerge, whether that's the use of dowels or bungees or perturbation, etc. But getting better at shutting up and providing a learning environment where the human body will evolve the strategy that they're choosing and being able to progress and periodize their exercises on. So I think my assessments have improved over time from patients that should have got better and didn't get better as quickly as you could have. My analysis improved by having biomechanical analysis available to see that, if I just look at your calf strength, I'm missing a whole host of very, very useful information. And then trying to look at sport specific skills coaches, but also, whether that's golf or kicking or whatever else, and look at how they do skill acquisition from a sport specific point of view, and then just taking those principles and applying them back to rehab, and sort of saying, well, look, if I create this environment, well, in theory, my running mechanics should change every bit as much as my 7-iron. And so I found that very enlightening and very much an ongoing journey of learning.
Okay, grand. Where do you feel that the current gaps are in literature then? As you're treating, as you're seeing these outliers and whatnot, where do you think that there are things that we need for improvement or areas we can be getting sharper in?
Yeah, I think it's research is difficult in that most injuries are multifactorial when you combine their genetics, their anatomy specific to that injury, and then their biomechanics. And very, very few studies look at any injury and look at it in that holistic capacity. And therefore, it's very difficult to be definitive in saying that this is or isn't the problem and this is or isn't the solution off the back of that. I think we should move more and more towards interventions that are individualized to that athletic presentation rather than necessarily to that injury. That's something we focused a lot on, in particular in our groin work, is not disregarding the anatomical diagnosis, but grouping them all together and sort of saying, well, this is how this individual athlete moves. I think that could apply very much to tendon issues as well. And then understanding the other factors, such as, if you're looking at measuring a success of an outcome in terms of speed of recovery, that not only is it the intervention, but it's how that individual athlete has adapted to that intervention. And so everyone's, depending on their nutrition, their sleep, their genetics, you will get a different adaptation to a training stimulus. But let's say the two of us have the same stimulus, so I have lots of young kids, so I get very little sleep. So therefore, your adaptation to that stimulus is going to be different potentially than mine is, or vice versa, as the case may be.
No so kids that I know of.
That's so judging our interventions on what we achieved, not on the duration of the intervention or the anatomy, I think is where our clinical practice needs to and is going. And I think research will continue to support that approach.
Grand. And have you got any reading recommendations for people?
I think my recommendation is to read broadly and rather than necessarily some specific topics. Obviously, in the pre-reading for the Big 3 muscle and tendon course, I've talked about Jill Cook, who we've had previously, her excellent papers on the overview of tendinopathy, and also some of the finished papers on muscle biology healing. But read broadly, both in terms of the pathomechanics of injury. Read broadly on strength and conditioning and how to achieve adaptation, and read broadly on motor learning and how we can create environments for our athletes to recover. Because ultimately, as I said, for the most part, the diagnosis is nearly the easy part of this. It's getting the required changes where the both physical and mental is the greatest challenge. So my recommendations would be keep a broad outlook on what you're doing.
Grant, you mentioned the course there. Hopefully this gives people a bit of an idea of what they can expect. Can you sort of give us an overview of what the listeners can expect if they are going to do it?
Yeah, I think it's trying to broaden your horizon on the management of muscle and tendon injuries in the lower limb, to give an in-depth understanding of muscle physiology and tendon physiology, how they respond to load in healthy presentations and how they become injured and symptomatic, to try and give you some perspective on the breadth of your assessment, both from a clinical point of view and revising all those special tests and your clinical assessments, but then also the breadth of your, if you want to call it your rehabilitation assessment or your biomechanical assessment, so that you can identify all the factors contributing to that presentation. And then to give you some exercise solutions to try and address those specific biomechanical and strength and power deficits, not only in the exercise selection, but the importance of the coaching cues and how those exercises are periodized and progressed to get ongoing progression and adaptation. So again, not so much that this is the exercise you need to do, but this is why we're selecting this exercise and this is how we're coaching it and this is where you might progress it, so that, like all things, you get some new exercises you can use on Monday morning, but also it gets the hamster running in the wheel to think about the other exercise that you are currently giving, and are they achieving what they're achieving, or actually are they, progressions on from what you're doing currently?
And Yeah, that's really important. And another thing is, like you mentioned, those coaching cues of also giving you more of an idea of what and how to say it to your patient as well. Because that's one of the things that definitely in my first few years of being a physiotherapist is something that I've massively struggled with, of finding the right things to say and not giving them too much of an internal focus, so that, like you mentioned earlier in the podcast, their body figures it out rather than you having to tell them, which then changes the way that they're going to adjust to the movement. And for anyone listening to the podcast as well, there is a code for €50 off, 50 Enda, that you can use as well. So yeah, enjoy, guys. How can people find you then?
Yeah, so on social media, I'm on Twitter and Instagram, Enda_King, and I put most of our research up there. And any particular interesting videos or content that I find, I'll try and offer up and share and steal other people's ideas and pass them off as my own. And hopefully people will find it useful, but feel free to drop me a message anytime.
Any other little last bits or bobs that you want to add for anyone listening?
No, I think, when you were talking about sports rehab and I was suggesting don't do it, like we're very lucky. When it comes to a profession that allows you to socially interact with people and make a big difference in their lives and their quality of life, there's very few professions to match it. But also, I think in terms of our understanding of human physiology and human movement and adaptation, it's just a minefield in terms of learning. So it can be overwhelming, or at least I still find it overwhelming. So I think what you're looking to do is just look at your current practice and sort of say, here's where I am and here's what my weakest link is, and try and improve on that first, rather than trying to do everything all at the one time and really drowning in all the information that's there. Pick small bite-sized areas, upskill yourself in that, and then sort of push things on from there, because you can make a tremendous difference the broader your outlook is on these presentations.
Grant, thank you very much. Really appreciate your time for being able to come on here and chat to us.
Great to chat to you, Sonny. Thank you.
Well, ladies and gents, thanks again for listening in, and we'll catch you next time. As always, wherever you're listening to this, we appreciate your time. And if you have any comments or suggestions, feel free to get in contact and let us know. Until next time.